In the mid-70s, there was a realization that if you're going to tackle tropical diseases, as they were called then, you needed two things. One was tools, diagnostics, vaccines, medicines. The other was people who were capable of doing research against those diseases within their own country.
TDR is trying to change a system, and has changed the system, by investing in people over the long term. It's all about having people trained to do the research and science, and then translate that through policy making that makes a difference to people's lives.
We're enabling these fantastic people to do absolutely groundbreaking work. So if we look at, for example, visceral leishmaniasis from Bangladesh, it's a horrible disease, almost a death sentence to be getting this disease because the drugs aren't good for treating and very difficult to remove from communities.
It victimizes only poorest of the poor living in the rural areas. This is a wonderful drug, but very sensitive to temperature. So nobody believed that this treatment can be implemented in the rural hospitals. TDR thought that if we could prove that this treatment can be given to the rural hospital, then the policymakers from the government, they will accept it, they will adopt it in their national program. We treated 300 patients. When I saw the result, I was the most happiest man in the world that time. The efficacy was 98%. We showed our result to the government of Bangladesh. So the national program adopted it for implementation.
দুই দশকের চেষ্টা অবশেষে কালাজ্বর নির্মূলে সফল বাংলাদেশ বিশ্বের প্রথম দেশ
People of Bangladesh are now very, very happy because globally we are the first country which eliminated visceral leishmaniasis as a public health problem.
When we started in Bangladesh 15 years ago, there were 20,000 cases a year. This year, there'll be none. You can't really get a better outcome than that. The easy answer to what is TDR's legacy would be to look at the things. So, 13 drugs that would not have been there that have had fantastic impact. Diseases eliminated. But truly, what I think our legacy is people. At the core of this is still our basic DNA of increasing capacity of countries, decolonizing the research, democratizing that research, and putting research into the hands of implementers in country who can really make an impact with this.
When I started here at CDIN 12 years ago, there was not good capacity, I think, in Colombia or in Latin America for doing implementation research. We know that we can share knowledge and experiences and support each other. We are like a big family. So when TDR launched the MOOC, a massive open online course on implementation research, for me it was very important.
The objective of this MOOC is to build competencies, knowledge and skills of health workers, health managers and policymakers to contribute to implementation research teams.
Because of the way that it has been done, the language, the examples, the videos, we realized that we have the participation of a very broad audience. We have researchers, but we also have practitioners, physicians that are actually providing services, implementers, and policymakers as well. Now that we are involving different actors in research, we are closer to actually provide solutions that respond better to real context and to integrate these solutions in public policy.
TDR has been a real trendsetter, really revolutionising the way that people do research in communities. Because in the end, the only way to tackle infectious disease is to understand the disease in the context of your health system, in the context of your country, and be able to respond to that, get the research, get the evidence for better delivery of the health services.
So if you take women, for instance, why do women not come to the health facilities? You need to look at it from a gender lens, trying to understand how it affects their access to health facilities.
It is a disease considered second only to malaria as the most devastating parasitic disease of our time.
Female genital schistosomiasis is popularly known as bilharzia. The symptoms basically look like regular gynecological problems, and so the women fall in between the cracks. So as part of our work on genital schisto, we interviewed a young girl. And I remember very well, she says, I'm a 14-year-old girl. I went to the health center describing what was wrong with me. And the nurse insulted me and said I was a very bad girl and I was having sex with men. And she was in tears.
Unfortunately, because it manifests symptoms similar to some sexually transmitted diseases, many victims stay away from medical centers and suffer in silence.
So when you are looking at things from a gender lens, it's not just an academic exercise. You are doing it to ensure that services reach people who need them. I have come to find TDR tools extremely useful to ensure that we have many more people who are trained on how to diagnose the condition, and many more communities are sensitized on what it is and what they can do to prevent it.
Scientists are part of their communities. They need to be informed by their communities, and they need to be able to translate that through policy making that makes a difference at a national and global level.
I'm excited about the next 5 or 10 years because I think that we are walking the right path.
The lesson that TDR gave to the world, think local experts, local scientists, local researchers.
We're talking about paying attention to the people that we are engaging with, paying attention to the social context to be able to provide better services.
The key for TDR is the common thread that's gone through its 50 years and its next 50. That sustained investment in people and in science, because that's when you make the biggest difference.
We've done this in one way or another for almost 50 years, and it still is a winning formula, and one that's absolutely necessary if we're going to make sure nobody's left behind as we try and make a healthier planet.